So I appreciate it, Dr. Melmed, but since then I've become wiser since 2009, and I was only a middle author there. So the debate question here is immunomodulator monotherapy should not be used in practice. And so what I will do is actually give a very basic counterpoint, in that the counterpoint title is a very sweeping statement. And there's a lot of subtleties, even what Dr. Melmed showed you on the left side with the box where they talked about potentially using in a low-risk patient immunomodulators. The fact is that on the right, where most, for example, Crohn's patients are, which tend to be more high risk, there was really no role for immunomodulator monotherapy on those guidelines. So what I'm going to do is I'm just going to present the data. So I'm just going to, obviously this is a decision, the data for immunomodulator monotherapy in different scenarios. And again, this is just clinical practicality. We just discussed the challenges of therapeutic drug monitoring with anti-TNFs. And I think many of us have experienced trying to do it with immunomodulators, which I think is the reason why it's not really caught on, despite very good data like Dr. Melmed showed. So this is, again, kind of small, but some of the similar graphs. And the fact is that immunomodulator monotherapy is not an effective induction agent. So there does seem to be, again, if dosed appropriately, we can keep that argument. But in general, how things occur, and the fact is that it takes up to 17 weeks. And the reality is that when was the last time that you started somebody on azathioprine or 6-MP with no steroids and just let them sit for 17 weeks? The fact of the matter is that you're really using it primarily as a maintenance or steroid-sparing agent. And so this kind of gets to the point, and the final conclusion of this was that azathioprine and 6-mercaptopurine had no real advantage over placebo for induction of remission. So as I said, I've also learned. And the AGA guidelines on the use of thiopurines really suggested against using thiopurine monotherapy to induce remission in patients with moderately severe Crohn's disease. Now, I will agree that there is efficacy as a maintenance agent at the right dose based on these older studies. And again, this is small, so I apologize, but what you can see here is that at those doses at 2 and 2.5 milligrams per kilogram, there did seem to be a benefit compared to those that were at 1 milligram per kilogram in this meta-analysis. And the reference is in your slides. But again, the fact is that we do know that there are more effective agents. And so again, the argument isn't really that if we really micromanage and fine-tune the immunomodulators, and it might be what we should be doing, but the fact is that in real-time clinical practice, what is occurring, there are more effective agents. And as I said, for those patients who are high risk, which most Crohn's patients are, we can maybe debate the issue of ulcerative colitis. Even the AGA guidelines really said that there's not even a role for immunomodulator monotherapy at all. And then finally, some of the newer studies don't suggest that it's an effective option. And you heard about a 30-year-old study, and I've maybe became wiser since 2009. So the fact is that in terms of how practice occurs now in 2015, where are the data? So this was a study published last year with early administration of azathioprine versus conventional management for Crohn's. The RAPID trial was a 3-label. Granted, it was an open-label randomized trial. And it had 147 patients who were immunomodulator and biologic naive, recently diagnosed, and we can debate, whether this is the right population or not, but they all had risk factors for disabling disease. So again, theoretically high-risk patients. And the study arms were immediate azathioprine versus conventional, which, you started azathioprine if you were steroid dependent, chronic active disease, poor response, or perianal disease. And you can see there that there's really no significant difference between the two groups. And then the Aztec trial, which was a Spanish study, again, quite similar, immunomodulator and biologic naive, which newly diagnosed less than 8 weeks. 2 study arms, they either got azathioprine or placebo, and you can see that there's really no difference in steroid-free relapse. So the debate isn't whether immunomodulator monotherapy is used in clinical practice. It's not necessarily that I published something in 2009 saying that as a middle author when I was much younger. The fact is that it's used in clinical practice. However, the guidelines don't recommend it as an effective induction agent. So It has efficacy as a maintenance agent, steroid sparing, but there are more effective strategies are available, and we're increasingly realizing that most patients, Crohn's patients, really probably fall into that high-risk category. And then newer studies don't show efficacy as this kind of top-down agent as monotherapy, meaning that you have Crohn's, you start it. And so with that, I thank you everybody for your time.